Dr. Rafael Fonseca. I'm a hematologist and I specialize in multiple myeloma. Today, we're going to have a special conversation with Cherie Rienker. She's a multiple myeloma patient who's been through multiple treatments and will walk us through her experience. Thank you for joining us. I just wanted to put a brief disclaimer. Obviously we have a lot of progress in multiple myeloma, and some of the topics we'll be discussing will be related to end-of-life care. So if you're a patient and don't want to hear about this, you probably can skip this video. It's all the human aspect of her journey and the decision making, but I just wanted you to be aware of what the topic of our conversation is. So thank you. Welcome to Innovation in Medicine. Today is my pleasure to have with us Cherie Rienker. Cherie's a multiple myeloma patient, and she and I met through work. Primarily we did together through the myeloma crowd and the group from Jenny Alstrom. Cherie has multiple myeloma. She was diagnosed in 2012, and she'll tell us about her story. It has been through a large number of treatments. By her count, she's been through 16 lines of therapy, including most recently things such as CAR T cells. Cherie is also an author. She's already finished through her first book, and it's working on her second one. The first one is called The Pilgrimage Without End. Now Cancer Healed My Broken Heart. She's working on the second one, which is also Pilgrimage Turns Health, Keeping Hope Alive. So we're looking forward to see that as well, Cherie. But first of all, thank you. It's a pleasure to be here with you, and I certainly look forward to this conversation.
Yeah. Hi, Rafael. I'm excited to be here, and I followed you and love the way you interview people, and I'm privileged and feel honored that you wanted to talk to me today.
Oh no, it's my pleasure, and I think this all really started from a conversation we had in Utah, in Deer Valley, at the myeloma crowd training for the myeloma coaches. And I think if I'm right, and maybe you can expand on this a little bit later, but you do want to maybe have this serve as a legacy for patients and maybe families of patients who may be dealing with similar prospects as you are now. But before we do that, would you mind just doing a brief overview of your history with myeloma, and also an overview of where you come from, as a person, and how do you come to be a myeloma patient ultimately?
Sure. Yeah. So, well, I'm Dutch originally. I was born and raised there. Born in Rotterdam. Came to the United States about 1989 via Boston. Was a flight attendant, massage therapist. My whole interest is just people and serving people, and so did that. I was an avid runner, biker, very holistically living. Worked at a place where they actually help people get rid of their insulin through a vegan diet and all of that. And then I decided to go to aesthetic school to make people beautiful on the outside and inside. I would say I always help people body, mind, and spirit. I was very holistic. I was actually raised in a Christian Science household where doctors were considered bad, medicine evil, and you just prayed your diseases away. My mother was very Christian. My father was actually agnostic and did not agree. And he would sometimes take us to the doctor behind her back. And then we would get better because we'd be on antibiotics or, whatever was necessary. And then my mom would get to go, see, prayer works. And we weren't allowed to tell her. And looking back, I really realized what an enabler my father was, and what a disservice he really did, not only to his children, but to my mother as well. And but it did put some fear of medicine in me, which is why I ended up becoming a holistic practitioner. But when I started to get sick in early 2012 and had to start going to doctors, they didn't know what was going on. I've always taken good care of myself, so I looked really healthy, but I just got more and more sick, more and more pain. Thought it was due to my job as a massage therapist, being a single mom, working 40 plus hours a week and stuff. But about 6 months before I was diagnosed, things just got worse and worse. Like I said, I was a triathlete and an avid hiker, and I could barely walk to the top of my stairs. with my daughter, and I spent every weekend in bed with low-grade fevers, unable to roll over in bed without excruciating pain. One day I stretched my arm and I popped a rib, ended up fracturing a rib. And so I started going to doctors more and more, and they just didn't know what was going on with me. And finally they saw I was severely anemic, and they made an appointment with a hematologist for about 5-6 weeks later, and the pain just got worse daily. And I went back to the doctor, and he said, well, if you can't wait for that appointment, go to the ER. And so that's where my book starts, that I went to the ER, was given morphine for the first time. The pain was a little better. And about 2 hours later, he walked in, and without looking at me, he said, well, you're severely anemic and you have cancer, because he found 3 tumors on T3 and T4. And so I was 44, my daughter had just turned 7, and my world as I knew it fell apart.
Before we go, just if you may, so how long was the delay from the time you started having symptoms until you actually were formally diagnosed? And a second question maybe to throw in there, I mean, the whole background you already alluded to and have shared with me, that was a shock, right? Because now you have to accept that you're going to be under the care of, you know, quote unquote, traditional medicine or Western medicine, if you may. But so that was a big shock at the time.
Yeah, that almost made me not do it. Mm-hmm. When you go through, I went to college called Clayton College for Natural Health, which since is bankrupted. But when you read all the books on top of your mother saying how bad it is, and that's all in your brain, and you're taught that chemo kills and it's bad, and you really believe that, when you realize you have to do this, I mean, you think you're going to die. And so to answer your first question, I really started hurting in May of 2012. And I remember going to an urgent care and just had this horrible pain in my back. And I said, I think I need a CAT scan. And the doctor said, we can't do that because insurance companies frown on the cost of that. So they did an X-ray, which didn't show the tumors that were growing. So I really believe that had that doctor taken that and gone with it, we probably, I was late stage when I was diagnosed, and we might have caught me much earlier and started treating at that point. But instead, I ended up with lung issues, like I said, low-grade fever, was losing weight, and just pain that would change from my sternum to my ribs. Went to acupuncturists, chiropractors, just anything holistically that I could, and nothing helped. So it was about 6 months of misdiagnoses. They tested me for AIDS, lupus, valley fever. I was living in Tempe, Arizona. And then when I started chemo, I was scared to death, obviously. And the first 2 months, actually, when you look at my numbers went up. And I remember, the Revlimid with the Dex and Velcade, just being so sick on top of the cancer that had made me really sick. And every day I would have 2 fevers. They would just spike, and I was exhausted. I couldn't walk from the couch to the kitchen. And one day I looked in the mirror and I saw my carotid artery, like really going fast and thick. And I asked my husband if it had been there, and he said, yeah, it had. And I had a 94 resting heart rate, probably because of the anemia and the medicine and stuff. But usually I was like 50 because I was an athlete. So one day I was sitting outside, and I really, at that point, just wanted to die. I wanted the fevers to take me. I just didn't want to fight anymore. And my daughter, who was 7, was playing outside, and I looked at her. And at that moment, I said, Cherie, you have to stop this. You have to make a decision. Are you going to fight this and embrace the chemo and modern medicine, or are you going to be afraid of it? Because I do kind of believe still in that body-mind connection.
Sure.
And so I made a decision to, instead of telling myself that chemo kills, which I believe the cancer and the chemo at that time were killing me, I started to see the chemo. I like always visualizing things. So every time I would get an infusion, I would see that as a tsunami of chemo coming through my body, wiping out the myeloma, and then retreating, and then healthy cells coming back. And so when I started doing that, I started feeling a lot better, and the numbers started going down. So,
And little did I know you were in our backyard. We didn't connect back then, right? 2012. I was already here at Mayo Clinic in Arizona, and I should mention also for the audience that's watching this. You and I have not had a physician-patient relationship, so I've never seen you as a patient. So I'm talking sort of as an interested human being to another, right? And in fact, that's why I asked you about some of the details, because I've now been participant in your care as well too.
right.
So it took that many months to get there, and then you started treatment, and you started feeling better. So that must have been an eye opener too as well, because suddenly something that was so negative became something that was helping you, right, with quality of life.
Right. Yeah. I mean, it was about 2 months in that I remember I was finally able to leave the house, and I went to the grocery store walking like a 90-year-old woman, going super slow, hanging on to the cart, but I was able to do it, and I started to enjoy life a little bit. But it was about, my doctor told me, 3-4 cycles of induction therapy followed by a stem cell transplant, and then you'll get your new normal back. And I'm translocation 1114, and I've been reading up on that a lot lately, and it does say that it's more resistant to drugs, it seems, at least in my case. Dr. Orlowski is my physician, and he always called my cancer not aggressive, but very stubborn.
Yeah.
And so I had to change therapy treatments 4 times in the 9 months of induction. And at that point, the chemo did start showing its effects with neuropathy and other things. We decided on going ahead with the stem cell transplant. And I said, well, what should a bone marrow biopsy be prior to stem cell? And he said, well, we like it to be somewhere between 0 and 5%. So, I'd seen the numbers go down, and I was hopeful, and it came back as 80%, 80.
Wow.
So after 9 months of induction therapy, I still had 80%. And so I was petrified of the stem cell transplant, because chemo had been rough on me, and I heard stem cell transplants like 100 times worse. And I became suicidally depressed because I wanted to get out of having to do the stem cell. And, the Dex wasn't a good medicine for me. They had to get me off of that eventually. One thing that I would like to say is that I think when a patient is diagnosed with cancer, there should be a social worker, like immediately. There should be an automatic appointment with a psychiatrist. They did not put me on anti-anxiety and antidepressants right away, which I believe at least it should be made available to us, all the option, not just kind of like the poster or the flyer in the office, but really your oncologist discussing like, this is available and do you need it? I was talking to the nurse who was checking in to me to see if I was physically and mentally capable of the stem cell transplant. And I was crying every time I was talking to her. And she said, well, it's okay. This is what happens. And then I told her, well, I'm starting to think of this letter I should call write to my husband and my daughter. And, somebody said how a brother died accidentally in a garage with the car exhaust on. And I'm thinking about these things, not wanting to think about it, but that was just this fear that I had no control over. And she told me, she said, well, that's not good. So they took me off Dex. They put me on antidepressants and anti-anxiety. And within a week, I became much more normal with that. So,
and sure, you've seen pretty much every drug there is for the treatment of myeloma. And I think for patients who've gone through this, I want to take the opportunity to ask you about dexamethasone. Dexamethasone is a big challenge, right? And I think oftentimes it's one of the worst drugs just because of how it ends up working with the human brain and how we're wired as humans. So would you mind sharing a little bit of that too as well?
Yeah. So initially I loved Dex because when I was so sick and so anemic, my Dex days were days where I was able to eat more than the 200 calories I was managing to take in the first couple of months. It gave me a little bit more energy than I had. And did not make me gain weight like it does other people. And I did not have the sleep issue because I think the Revlimid and the pain medicines definitely like overcame it. And I've heard a lot of people that say they get angry with Dex. And for me, the side effect was severe depression. I remember once I was better months in and had to take myself to MD Anderson. And I write about this in the book, that I would literally have to look at and point out to myself, cloud, tree, yellow car, because every time my mind I would stop from thinking consciously about something, my mind slipped into how am I going to keep myself from, this horrible transplant. So I call them suicidal fantasies. I didn't want to act on it. I didn't want to be suicidal. So I don't believe I was suicidal, but I think that, and then another thing, 2 months after being diagnosed at 44, my period stopped. So I went into menopause, which, apparently that doesn't always happen. But so, on top of being a healthy, holistic massage therapist, not only did I have to get on chemo, which I didn't want, I was incredibly sick. I was thrown into menopause, which I always say my menopause was easy because my cancer overrode it. But probably some of these side effects had something to do with that as well. But yeah, I think Dex is it's a challenge, and I know it's a necessary evil for most of us.
Having gone through all these treatments, which one would you say was the one that you got the best value from, meaning that, you tolerated well and you did well? And what was the worst part in your personal experience as far as treatments?
Yeah, so for me, I always say that carfilzomib, I have been on carfilzomib off and on, I think a total of 3 years. Velcade caused me severe neuropathy, not just in my hands and feet, but I started having these shooting pains through my legs. So I must have been one of the very early people in 2013 who started carfilzomib. I never had any heart issues. The nausea, everything was very tolerable. And so I never minded that. It was an 1.5-hour infusion, so not too long, but enough to just relax and get your lunch at MD Anderson instead of just sitting in the chair and, driving 2 hours and for a 15-minute appointment. So it felt like I got something out of it. And then the other one that I enjoyed that I managed really well was daratumumab. Daratumumab was a drug that I did in December of 2015, right when I came back from Colorado, where I wrote the beginning of my book. And I actually went up to Colorado to try my own little trial of one, I called it, at that point, I'd relapsed, I think, from 6 lines of treatment. And so, we all Google, we're all guilty of that. And Rick Simpson oil started popping up everywhere, which is cannabis. And so I had to leave the state to try it. It, by the way, didn't work for the cancer at all, but it helped with the neuropathy and sleep and stuff like that. Not enough for me to love cannabis. I mean, it makes me paranoid and I just don't like the drug. But when I came back, I went on Pomalyst, Dex, and daratumumab. And a couple months later, for the first time ever, my kappa light chains went in the normal range. And they stayed there for, I think, as long as I did it every week, they went down, and then they were in this beautiful place. I still had Benz Jones. I still had an off ratio, but I considered myself in actual remission for the first time. But then they did every 2 weeks. They stayed stable. And as soon as it went to every month, they started climbing up. And I've never been somebody who bounces up and down. Once the trend goes one way,
Now, were you getting the daratumumab single agent back then, or were you getting other agents with the daratumumab?
No, I got Pomalyst, Dara, and Dex with it.
Okay.
Yeah, I've never done just a single agent.
Yeah, as we talk in the seminars, it's very, very common, of course, that we go through combinations for most patients. And so you told me about carfilzomib was good, Dara was good. Which one was hard of the treatments? I mean, maybe it goes without saying, transplant does have a significant component of hardness.
Yeah.
What is your opinion about some of the hardest parts of treatment?
Bendamustine, which a lot of people don't haven't heard of, because
Sure.
it's one of those where you start to reach, that may be very, very nausea. Nausea has always been an issue. People say, oh, you look great, you're so thin. I call it the chemo diet. I've never been able to get my appetite back, but that one in conjunction, I think, with carfilzomib and Dex, and then I had to do Feradac, which was a rough one as well. It shot my numbers down, which was great, but then they shot right back up. Revlimid, I can handle 5 or 10 milligrams, but 25 milligrams, oof. I mean, that was, I don't know if when you're 118 pounds with clothes on, if that has
Sure.
anything to do with I do think, compared to what I hear some other people, that generally the things seem to hurt me worse, especially the nausea part of it.
Yeah, no, and I think you're right, of course, and there's some pharmacology studies that are always done, but 25 milligrams for someone who's, over 100 pounds, quite different from someone who's close to 300 pounds, of course.
Right.
So that goes without saying. Now, most recently, there's a couple of experiences you've had. So one of them I know was venetoclax, and the other ones were the CAR T cells. Would you mind just saying a word about those two?
So CAR T for me, I wrote a long article about it. I should send it to you so you can post it with this. It's how CAR T gave my life back. It was a tough experience to journey because it was a 14-hour drive away from where I lived. And the first week was absolute hell because, again, I got extremely nauseous and vomited so much that it got into my lungs. So the first week on top of RSV or the toxic.
The cytokine release?
Yeah, cytokine release. I also ended up with pneumonia. So so that was really tough. But once I came out of that week, I was a straight line going up. And I think all the cancer was killed in that week. And 3 weeks later, I saw something I'd never seen before, a deep dip below normal with my kappa light chain. So I ended up having a beautiful MRD to the 10 to the -6 stringent remission that lasted probably between 9 and 12 months. At 9 months, I was still in complete remission, but at 12 months, that had changed. So that was pretty devastating because I really thought that was it. And before CAR T, I said, I'm never going to go back to chemo anymore because at that point, I did feel, with my platelets always being low and everything else being low, I started to see, indeed, there comes a point where both the cancer and the chemo can be destructive to the body. And so then after that, I started hearing about venetoclax, which is good for translocation 11-14. And we were hopeful about that. I didn't like the side effect that was pointed out to me when I had to sign on the dotted line that you can get infections that can kill you. And I remember Dr. Lowski kind of looking at me like, sorry, but I got to tell you this. So I went into that very hopeful, and I did 200 milligrams for 3 days, and then went to 400 milligrams, and then got this horrible sore throat that ended me up in the ER. And they don't know if it was mucositis or a doctor friend I spoke to suggested it might have been radiation memory because it was exactly in the same place where they had radiated my throat. But I was unable to eat, drink, or do anything. And so we had to get me off of it. It did show in just 5 days that my numbers dropped by 20 points. At that point, I was like, well, this is the end of the line. We tried, I went to Seattle. There was a CAR T that approaches the whole myeloma in a different way, but I didn't qualify at that point. And that's when I kind of started to say, again, enough is enough. And I started to realize every time I thought about any kind of treatment or would read about patients and what they were going through. And because I'm a big advocate on Facebook, I have seen so many people dying such unpleasant deaths. And I just realized there's two types of patients, the one that goes out fighting, as in chemotherapy fighting, and then those that just come to the realization that we've kind of gotten to the end of the road. And I'm definitely the latter, not only for myself, but what it's done to my daughter over the years. She's got mental issues because of PTSD and stuff. I do, my husband does. So we're not the kind of family who can afford to take mommy for platelets every other day and, all that stuff. So that's at a place we're at right now, actually.
Well, thank you for sharing that very personal part. And I wonder if I could just probe a little bit more. I know a part of the genesis of this conversation is you wanted to give a legacy for, for patients who may think, this is enough, right? And so we live in a world where there is no doubt we have many more options for the treatment of myeloma. So things have gotten way better, but things don't always work in the way we would want them. And even though we have situations where there's very long responses, sometimes there are situations like you have faced where there's not that many options for treatment. And so what went through your mind as far as coming to this decision and saying, I don't want to get any more active treatment?
One of my favorite movies is a movie with Deborah Winger and Anthony Hopkins. It's called Shadowlands, and it looks that she has something like bone cancer, maybe even multiple myeloma, and she gets treatment, and then which was radiation, I think in the 30s or something. She comes home, the doctor says, go live your life, no promises of how long. And then when it relapsed, that was the end, and then she passes away. As a flight attendant, interesting analogy, I used to do flights with a whole bunch of kids in the back, and their way of annoying flight attendants would be for all of them to ask us what we had in our drink cart. And so I started joking them back by saying, I have apple juice, orange juice, Coke, and 7-Up, dark and light. And they knew I had more, but I feel we live in a world now where two things: we have so many options, and everybody who wants to paint their house white understands the problem of which one of the 50 whites am I going to pick, right? And then the same with myeloma. I am so grateful, and I'm so behind all the research. And so this is nothing against that, but it's almost, and doctors such as yourself, you guys are fighting so hard for us and want to do everything. But I think it's almost like it seems forbidden for a doctor to approach the subject of, we could do some more, but have you considered maybe just having a good quality of life for the rest of your life? Because most doctors and scientists that I've been able to talk to in a very honest one-on-one conversation, when I tell them that I know I'm in a losing battle and I give that to them, that knowledge, none of them have ever disagreed with me. And so I know a large majority of us patients still are like me. And I don't think it shows defeat by saying, enough is enough. And, oh my God, Cherie, but you're young and you have a young child. I think there's a lot to be said for realizing what your boundaries are, knowing when enough is enough. And I think even with the help of a doctor but we usually don't give ourselves permission. Society doesn't really give us permission. Everybody's into, we're fighters and we got to keep fighting. And when I posted on Facebook that I was done and what I was thinking about, I never had so many likes and shares and comments. It took me 12 hours to respond to everybody,
Sure.
Of people that considered me brave in acknowledging that really what I could do was maybe buy 1 or 2 months here, maybe even 6 months, but the price it was going to come at was going to be a much worse lifestyle. And I don't think I feel in the position emotionally and physically to redo all that without the same hope that I had prior to the CAR T. And that's why I came to that conclusion.
So let me put a question, maybe a shameless plug for some of the relationships you have developed through this journey. So you start, from a process where it's hard to trust medicine. And I think from the way you've talked, I know you have some physicians in Seattle and physicians at MD Anderson, and we'll talk to them. We'll let them know this is happening, of course, too, as well. But it sounds like that has evolved into a deep human relationship in which they talk to you about your concerns. And so what would you tell to patients as what can you tell us about your experience that maybe would be useful for other people as they think about this tough conversations with their doctors?
Yeah, I think for me, I was raised in an upper class Dutch home where my father was the CEO of a life insurance company. So we had a lot of wealthy, important people coming into our house. My father was one of those, and I saw him in his underwear and stuff, you know. So I have deep, deep respect for scientists and doctors such as yourself, but I also look at them, I look at everybody as equals. And so I have no fear to walk into an office and with respect, just treat my doctor the way I would treat everybody, just respectful conversation. So I have no problem throwing the uncomfortable questions out there, even if I know they make my doctor, Dr. Lasky, feel a bit uncomfortable. And I've sometimes jokingly said, I'm either your favorite patient or your least, because I tend to put them on the spot with these things. But I think, yeah, having a real honest discussion about all these things. My father always told me it's better to ask and hear no than to not ask and not know. So don't be afraid to be personal with your doctor and really tell him about your deep concerns and your fears. And if he doesn't know the answer, ask him, you know, like direct you to the psychiatry department in the clinic or maybe outside or anything. Like, you know, we wait long in those waiting lines to get in the office. And I feel great doctors are the ones that really, they're not looking at their clock, but they're looking at you and they're willing to listen to you. And haven't met so many doctors and scientists at Celgene and Janssen and yourself at other conferences and stuff. You guys are just wonderful, beautiful people that often got into this profession because of cancer in your own family, is what I found out. And just the deep caring, and just because you wear a white suit or, you know, a nice suit doesn't mean, like, I wish that patients wouldn't feel the block that there might have been in previous generations, but certainly I've never felt that coming from doctors. So
no, I think there's quite a bit more symmetry, and of course there's you know, information was 50 years ago, it was possessed by a small group, mainly physicians, and the you know, access to information was very hard. Nowadays it's not the case. I mean, there's obviously a lot to be said by knowledge and, you know, the experience and all of that, but I think we have a more horizontal sort of relationship in that, you know, patients can contribute significantly to their care. So, and I'm going to use this as a way to ask you another question. I think one of the things I'm sure you know now is the complexity of myeloma. And so we frequently advocate, and this is not to be self-serving, but that patients should consider the engagement early on in their treatment in myeloma. And I presume probably this applies to most other cancers as well, of a specialist in the area. So, you know, as a patient, probably you have some comments in that regard too as well.
absolutely. And so I have a couple of thousand of myeloma friends on Facebook, I think, at this point. And when they come to me, first of all, I always tell them, I'm not a doctor. I can give you my experiences, but the first thing I say is find yourself a myeloma specialist. And I've heard some horrific stories of the mistreatment of myeloma patients being denied certain things that a myeloma expert such as yourself would absolutely grant them. So I think it's absolutely important to do that. I also, just to put in a plug for both Dr. Tony Blau and Jenny Almstrom from Myeloma Crowd, things like All for Cure, which is Tony's baby, and Health Tree, which is Jenny's, where people are so afraid of their information being misused. I'm a big advocate of sharing my stuff. I think this morning's comment on or post on Facebook was, today is a happy day. I'm grateful because I had a good bowel movement, which is very hard when you're on opioids, right? Sure. So we got to be grateful for the small and not so small things. And as a colon hydrotherapist, I know how important your colon bowel movements are for health. So these are all forbidden things to talk about. But I think if we have a place where we can put all our information and allow scientists and doctors and even fellow patients to see, with or without our name. People know everything about me at this point, and that doesn't harm me in any way. You're just not going to get my social security number, you know? Sure. But I think that would help researchers so much to get us to the next generation of a drug that might get us to a cure. So why not? Why not share that information? You know, I don't think we have anything to lose, and I think we have everything to gain.
Yeah, no, thank you for that. And that obviously involves, in some instances, participation in clinical trials, which is
Yeah.
an extra level of trust in that relationship, right? And there's this description of the patient-doctor relationship being a fiduciary responsibility, where we really have to be focused on doing the best for the person who's entrusting us with their health. When I tell my patients, of course, you do the heavy lifting, you do the hard part. You know, we're advisors, and we like to provide options, and we like to provide guidance of what may be the next best steps. But, you know, at the end of the day, it is the patients that do the heavy lifting. And in that regard, and maybe we can say a couple of things about clinical trials. Clinical trials, you know, they're built on that trust, right? So clinical trials, there's a whole framework behind them. They go through the ethics committee, they go through scientific review. There's a lot of conversation that happens before a clinical trial. But at the end of the day, it is the person who signs on the line saying, I agree to participate in this trial. What has been your experience with clinical trials?
Well, for me, especially somebody who came from such fear to go into clinical trials, it was I evolved, and now I'm a huge fan of it. I mean, from personal experience, I will tell you, or I'll tell all your viewers, that when you're in a clinical trial, you're being treated like a queen or a king. I mean, doctors are really on top of you. So, so the care is actually, if I could say it that way, almost better, because they have to be wary of anything that can happen. People have called me brave from like partaking in the CAR T trial, but when you have certain death in one hand and the possibility of a good life, you know, in the other, then it's an easy choice to join the trial. But I've done a couple of articles about, one was called To Try or Not to Try, that's the question. And then recently I wrote another one, and there was actually somebody from one of the pharmaceutical companies who texted me the other day and said, Cherie, you know, I respect your choice of where you're at right now, but have you considered this other CAR T trial, which accepts previously treated patients with CAR T? And so I went to Brian McMahon, which probably most of your viewers know from Spark Cures, who does an amazing job setting people up. And I'm like, hey, Brian, what about this specific trial? And he said, well, I looked into it, but you don't have an M spike, so you don't qualify. I've never had an M spike. So I told this person that, and he was like, oh, shocks. You know, and I said, well, welcome to the frustration of the world of patients trying to get into trials. So what I found, that there's not necessarily a lack of adult patients versus, you know, the 80% of children that go in, but between, you know, travel, how good are your kidneys, do you have enough myeloma, do you have enough ANCs, do you have enough platelets? I mean, it's very tricky to be in that fine space where you'll qualify. You need to have stopped usually, or with the CAR T, I had to stop with treatment and had failed the previous. And so then my cancer kind of spiraled out of control in those couple of months. So it's a very fine balance of getting into those trials. So if legally that would be like, why was the M spike necessary for that one? Why can't my progression, which shows up in my bones and in my kappa and my Benz Jones and stuff, why could that not be used? So that's maybe something for scientists to consider, you know, who create these guidelines.
Sure. No, I think that's a very good point. That I know people look at this constantly. I mean, there's some way in which you need to measure, but arguably that can be done through the free light chain, the urine. There were a lot of restrictions in the past which have been removed. So in the past, there was language like if you had any cancer, and you know, some people were excluded from trials in the past if you had like a skin cancer, which makes no sense.
Yeah, right.
You know, the reality is this whole thing with cancer is just that you know, you can tell if someone is responding or not. In myeloma, is very clear. We do have good markers. So I think your point is excellent, and people need to find ways that we make them available. You know, there's challenges like you state, for instance, with the washout periods. It's a big deal, especially when we're talking about CAR T cells and bispecifics, because, you know, sometimes you just can't afford that much time without treatment.
I know people who have died, literally died in that washout period.
Yeah, that's really a problem, something we need to look at. And since you mentioned Brian, maybe we've done a series. It's edited, it's not posted yet with Brian, but we'll share that as well too, because the work they do with Spark Cures is just absolutely amazing, connecting people with the right clinical trials, right?
Absolutely, he's the best.
So let me go back to another point, and I want to ask you a little bit about hope. But before I do that, I'm thinking of the word support, and the word that comes to mind is social media for you. I think social media has played an incredible role now in how information is disseminated, but also how patients support each other. So in fact, we often are invited or participant in some of those groups, and I can tell you, and maybe not today, but there's at least 2 medical interventions that were brought up to my attention because patients have heard about it in social media, that I thought, yeah, that makes sense. We should consider maybe this change. What is your experience when if I put the word support in social media? How would you describe that because there's a lot of people that are kind of wary and perhaps not as keen on participating, right?
Right. So, and probably sadly, those people will probably not see this, but
that's true. I'm sorry.
Oh my gosh. So when I was first diagnosed, my husband Googled what myeloma was, and he heard that it was a cancer for elder, mostly overweight African-American men. And so I felt so lonely. I thought I was the only younger mother of a young child who had this. And I don't know how accidentally I ended up with 2 women who were on Facebook and then told me that there were Facebook groups. Once I became part of that, I also didn't have, my husband is not a emotionally supportive person. I'm not talking behind his back because he'll tell you that straight out. So he can't handle the cancer, and my daughter was 7 and right now is 13. So it's not something that you can go to that. And so I think emotional support is so important. And after it started happening for me, I would say somewhere in 2013 that I started becoming part of these groups, and then people started coming to my page. And now I find all the support that I could ever wish for on my page. And I think it's one of the reasons I'm still here. I really, really, truly believe. I was talking to a doctor not too long ago who thought this whole Facebook stuff was just kind of silly and how we're all like Google doctors and stuff. And I said, but the emotional aspect, which for me, I leave a lot of the science just up to, people like you. I really trust in my doctor, so that's great. And then Brian McMahon for the
clinical trials.
Right, but for as far as emotional, there's nobody like a fellow myeloma patient or even caregiver that truly understand where you're coming from. My neighbors are like, but Cherie, you look so healthy, so they don't get what Dex does to you or what this fatigue that these things do to you and stuff mean. They're just going like, come on now, you got that 7 years ago, like that's not done yet. So to have that on a daily basis, just any time when you're feeling lonely or a little down, and you can go on there and you see people that have it much worse than you celebrate each other's successes, you mourn each other's sadnesses, and it's become a huge part. I call it my tribe. It's my family.
It is remarkable. As you were speaking, I was thinking, cancer always affects the whole family and the friend of circles of whoever is affected by this, and everyone is ill-equipped to deal with this from the emotional perspective, right? Even highly competent people, maybe even professionals that are trained. I'm sure, psychology spouses of patients with cancer are still going to struggle with that, and they struggle in multiple ways because they also have the inherent limitations of the dynamics of how we relate to each other in our personal lives and with our friends. You bring the example of your neighbors, but I think that sort of the third-party independence plus the deep knowledge that you can get from a group like that, I can imagine just as invaluable, just because, one, I think they will understand better, but also maybe it's a little bit easier to have that communication. I always say, try to teach your spouse to do downhill skiing in the snow, and you're going to be in trouble, right? But getting an instructor is going to work out just fine. So maybe it's something parallel to that.
Probably probably has a lot to do with it. I mean, even as a massage therapist and as a flight attendant, strangers will come to you and share their whole story much easier than your friends because you're safe as a stranger, right? I mean, you can tell all the bad stuff. You know, I would have passengers on a flight to Europe come to me and tell them about their miserable relationship with their wives, but then they were safe because they went off, and it wasn't like I was their neighbor and I was going to tell their wives. So in that same way, it seems like my friends around here, they just want to know Cherie, you know, the mother of their child's friend and stuff. But on Facebook, we get intimate, you know, real quick, like I said, talking about our bowel movements or our nausea and our food and what our blood tests are, because there's just this trust, but then there's also just enough space where they're not going to gossip behind your back to the family members, you know, so there's a safety in that.
Yeah, that's sort of a very interesting dynamic. And also, I mean, there is content, right? I think sometimes there's misconceptions. I'll tell you one of the most common ones, and I always tell patients, the first thing I tell them, everything I tell you is easier said by the doctor, but you know, transplant is a safe procedure. It's a big deal. I mean, you're going to be out of circulation, you have to recover, but it's a very, very safe procedure. And you know, I would say one of the most common scenarios is having to explain to someone, yeah, it would be best if you don't have to get treatment, but you can get through the transplant. And I suspect, you know, you learn about some of those things through social media as well too.
Right. So there's people, you know, it used to be me asking all the questions. Hey, I'm doing this. I'm scared. You know, daratumumab group, like, oh, I don't know. And now I'm more like the seasoned one. And I hear that, and I'm really happy to pay it forward. And in the last couple of days, I've spoken to 2 people in particular and gotten this one friend of mine now off to get in touch with Spark Cures and Brian McMahon and to really pursue the trial that he wanted to get on, because I reminded him, as in my case, that the longer your doctor's just going to push off the trial and you're running out of options, your immune system at one point will have a much harder time to recover to the point where you then won't qualify. And just this morning, he got back with me and he goes, Cherie, thank you so much. You made me decide. Next time I go to him, I'm going to say, I want to. Instead of talking about it, I'm going to say, this is what I want to do next. And that's what I had to do with my doctor. So it's great to feel that you're helping people for real.
You know, I'm going to switch things a little bit to go to hope, but I'm just going to put in a comment to what you just said. I always think an informed patient makes for a better patient, ultimately for themselves. And I'm going to take this to an absurd, you know, extreme. But if I have to spend half of my time sorting through faxes,
right,
you know, that is time that is not used for meaningful conversation, in-depth exploration of what may be some of the treatment options. So that doesn't really make that much sense. So I think patients that are informed, you know, I love when patients know what we're talking about, and it's not that I expect that or demand that, but I just think from a patient-centric perspective, it helps you a lot. And you know, I always tell patients, track your labs, and you know, can use things like Health Tree or even a spreadsheet. But you know, I want to make sure that we spend the most of our time in meaningful conversations. So that's very important. Let me just switch gears a little bit. Hope, and I know in next book you have the word hope. So how does one think about hope at, you know, at the various stages? And I think you alluded to this before, sort of it changes from where the aspirations go from the durability of treatment, and how does hope change when one is thinking about, you know, maybe I'm not at the point that I want to receive any more treatment.
Right. Yeah, so that's the reason that I wanted to keep keeping hope alive, which at the time that I decided on the book had everything to do with my little turmeric ginger tea recipes and stuff, to you know, Epsom salt baths to kind of draw out the toxins, kind of going holistic again, and just kind of telling my story, you know, of how I got the CAR-T, how it saved my life. Now I live happily ever after, and minimal residual disease negativity. And then came the relapse. And so once I picked myself off the floor, I always allow myself to mourn, because I think to just walk around with a smile on your face like everything's fine. Yes, you guys always get to see my face when it's smiling. I'm not going to show you on the days that I've been, you know, haven't dressed myself in 3 days and I've just been a blubbering fool, which I am, like I think everybody else. But I do believe there comes a point where you just have to have a talk with yourself. And I literally stand in front of the mirror, look myself in the eyes, and tell myself to put my big girl pants on. And so one thing we all have in common, you and I, Raphael, have that in common, is that we're all going to die. Death. You know? And so kind of in the thought of misery loves company, I know I'm not the only one who, I'm just more aware of what I'm going to have to go through. But, you know, I know I'm not going to be alone. It really doesn't matter what you believe in. I believe in concentrating on today and the now, and wanting to make today absolutely the best day that I can make it. And I do that with the knowledge in my head that there may not be a dental appointment in 6 months, right? Or there might not be an eye exam in 9 months from now. And I was just talking about it with my husband last night. I said, what is so weird right now is that I'm looking at the end of my life, and I know there might come a date, and then there's not going to be the next day. Like, that's going to be the end of my life. And I used to think that people that had a massive stroke or heart attack were the lucky ones, because you don't have to give death any thought. And in the last 7 years, haven't thought about death a lot because of the way has shown itself to me. I'm actually very grateful, because I've been very open to making the best of not only my life, but the life of people around me. I've had a much more purposeful life, because I know that how fragile life is. So things that I used to sweat about, 7+ years about, and then most people worry about today, they're no longer of concern to me. So I feel like the veil is beginning to lift, and I'm kind of disconnecting from the world and all its problems. And it's hard for people to understand that is actually a very peaceful place to be, because we just fear death because we don't know what death is. But I'm a silver lining kind of person. And so there's good things to dying. I mean, I don't have to worry about growing old and lonely. I'm like, I literally look for these things that we don't think about. I don't have to worry about my 401k running out, and I can concentrate on the negative, that I won't see my daughter graduate high school, or so many other things. But instead, what I choose to do in my mind, and I do believe it's a choice, is that I choose to emphasize the negative things I don't have to be part of, and instead really making the most of the positive things that are still in the cards for me and my daughter and my family and everybody that I hold dear. So I believe that the only thing we can possibly take with us when we die is love. And the main thing that I want to leave behind is love. And so my saying now is, it was always about love anyway. My life, I want it to be about love. That's how I want to be remembered. And, and that's something I want to really drive home in this book, that life. In the first book, I taught people how you can live a good life despite having cancer and being on chemo nonstop. And in the second book, I want to drive home that you can live a good life, end of your life, despite knowing that you're going to die.
Well, thank you for for sharing that sort of very deep and personal aspect of where you are right now. I think one of the hardest things, from what I've seen in patients with cancer, relates to the uncertainty. And there's a lot of stress in you're testing, you want to know the test results, you have the CAR T cells, you do that, and then it seems not intuitive, but sometimes if you remove that uncertainty, I guess if I could put a word, there's a peace that comes with that at least you know how you can focus your time and your energy at this point.
That's exactly what happened to me, actually. About 4 months into the CAR T, after the CAR T, I started to have severe PTSD, and every test was just horrifying. And once I relapsed, and once I decided really enough is enough, there has come a peace that I didn't think was going to come. That what I know, the numbers are rising. I know that I'm going to get to a point where pain is going to become unbearable, and I've put safety guards in place right now that I know how I wish the end of my life to look like. and stuff. And so with that, now I actually have a lot more freedom to really enjoy every day as it comes without worrying about what the next tests are going to say.
You know, I think also one of the things I've seen it is that testing that becomes so hard. I sort of sometimes joke with my patients. I wish I could have like a SWAT team that comes and draws blood from you, and you don't even know. You don't even have to be waiting for the call or the portal to show the results. And then we just let you know what the results are, right? Because it's just that period of uncertainty again. Now, you did allude, and you said one of the things we have certain, and you and I share that, is of course our own mortality, right? But it does become certainly much more real and tangible when you're dealing with a diagnosis like yours, and you're very self-aware, and you're more sort of time conscious when it comes to that. And I mean, does one ever get used to that, the intensity of that thought about mortality?
Yeah, I honestly feel I have. I have a good friend of mine who's a documentarist, and he's making a documentary right now about medical aid in dying. And we've been talking about death a lot. And he said, Cherie, the difference between you and other people is that a lot of, like, you could be 20 years old and a healthy young man or woman and say, well, I'm not afraid of dying, because you're not, unless you have an accident. But to be close to dying and saying you're not afraid of it, that's a whole different type of brave, he called it.
Sure.
I don't know if it's a brave. I don't consider myself brave at all, honestly. And I always tell people I'm no different than anybody else. What I am is a philosopher at heart, and I'm analytical, and I'm a deep thinker and stuff. So I give this a lot of thought. And I've come to the realization that the more I embrace it and the more I think about it and study it, the more normal it becomes. Just like before having cancer, you would never think that you could live a normal life with cancer and treatments and go into the hospital every week. And people that don't have cancer, they look at you like, how do you do this? Well, it's really the same with a terminal illness, and knowing that, like the prognosis for me is less than 6 months without treatment. So really it's the same. So instead of being afraid of it, I've befriended death. So I read about it and I look into it, and the more I understand it, and there are certain things that I want to do to have some control over it, as you know. But by doing that, then it loses its stigma, its fear. I had a friend who had to no longer be friends with me for years because she couldn't handle the C word. She just wanted to be there for me. And then one time she came over, she saw I was really sick in my early days, and she told me we were going to do nails together and hang out together. And I brought up the cancer, and she left and she wrote me a letter. She said, I'm so sorry, Cherie, but I can't be around you. It's too scary to me, and then I came to the realization, I was like, F cancer. Like, I was like, I'm going to say it like 5 times really loud. Like, don't be afraid of the word. That's really all it is a word and a disease, and we can overcome it. Or I've always thought cancer will never get me as long as it didn't get my heart and my mind. And so even if cancer gets my body, it didn't have to. I don't feel that I've ever succumbed to cancer, because I didn't allow it to. I mean, I did initially, but now it no longer makes me depressed. It doesn't make me sad. It just is what happened to me. No reason asking why me, no reason saying it's unfair, because life's unfair, as we all know,
No, and the why is always the wrong answer. One of the things that I'm thinking, one of my favorite books is Viktor Frankl, with Man in Search of Meaning. So he talks about the two approaches as, you can be someone who's in the advanced phase of your life, and you see the calendar on the wall, and you see that every day you tear one more page, so you see the calendar getting thinner. I think you're an example of the exact opposite. So he says there's people who will see at the calendar, every time they get one of those little pieces of paper down, they fold it, they contemplate it, they think about what that has been, and they cherish it, and they save it with them. So they're not necessarily looking at the thickness of the remaining of the calendar, but they're looking at, what has been done with all that paper. And I think, because of your personal life, but also because of your work with the myeloma community, you're a great example of the latter.
Well, and even for me, I asked my daughter last week, I said, how am I as a mom? What can I do better? I've always said when we're done learning, we're done here on earth. So I started learning difficult words, the other day. I'm like, I don't want to, just because I know I'm dying doesn't mean I want to stop learning. So I make my days really full with writing, with reaching out to people, with visiting people. I give myself the freedom to really do the things that I love, which has to do everything with serving people and just connecting with other human beings like with you. So I have a lot of work to do before I'm gone, and I have this book to finish. And so I don't feel like I'm waiting for death to arrive. I'm going to be too busy, and then it'll just happen.
Cherie, I know you've been very generous with your time, but I want to make sure we sort of close with you having an opportunity. If there's anything else you'd like to convey a message for people who may eventually face this in a situation such as yours, and how do you come to terms with that, and how do you go live that meaningful life that you're living right now?
Thank you for the opportunity to do that. I would tell those people, first of all, be kind to yourself, be forgiving. Do not think that where I am today, I didn't get by taking one step forward, two steps back. This is a process. So to get to the place of acceptance and surrendering of what is to come, you have to be gentle. You have to allow yourself to grieve and to mourn and to be angry and all those things. I do believe that that's a normal, healthy part of grieving. So to just pretend to put on a happy face, I don't think you're doing yourself or anybody around you a disservice or a service. I believe absolutely make peace not only with your own past, but also those in your past that have either hurt you or you've hurt them. Like, be willing to take on the uncomfortable conversations. And, I've been open about my struggles with my husband. And in my last post where I said where I was at, I said, I don't want to be angry at my husband anymore. I want to leave this world, totally having forgiven him and not being angry, because I don't want him left behind with guilt, nor I want my daughter to look at him with resentment. So, so that's a goal, that's what we're working now towards. So having the time, having the knowledge that you're gonna no longer be here, that you're gonna die, actually gives you a wonderful opportunity to do these things if that's what you want. And I think why would we not want to do that, right? So
Right.
Sadly, my family, I asked my brother, my parents to this day are in denial about the fact that I have cancer. So I've just forgiven them from afar and know that they just did the best that they could with what they had to deal with. And I'm at peace with that as well. And that was very important to me. So,
I can share, and I share this part of the story with you before. I did live through something similar from the caregiver perspective with my late wife. And there were some people that were close to her who just could not deal with it. And I think it took me a lot longer afterwards to reach that point of forgiveness as well too. So I think being more proactive about that makes a lot more sense. Let me ask you one more question, if I may. People think about this concept of, the war on cancer, and you're a warrior, and rightfully so. There's a lot of people that don't like the terminology because, if you lose, were you not courageous? We're not a good warrior. But then sort of the counter to that is, it's truly a battle. I sometimes feel like, when I come back from a long day in the clinic, and, I just feel like you're one of those movies from World War II where you want to sit, with your back against the wall and just, maybe taking a drink from a canteen and saying, boy, that was tough. And I'm sure patients feel that more so than we do. What are your thoughts about that terminology?
yeah, that's interesting because I've flip-flopped on that, which is fine because that's part of evolution, I think. But somebody said the other day that they definitely did not agree with the words warrior and battle and everything, and they were offended by it. And I said, well, 6 years ago, I very much agreed with you. I said, but at this point, 7 years in, hell no. I'm a warrior. I'm a fighter. I said, the way I look at it is that I've always said, I feel like there's a war inside of me and I was drafted for this. So this is nothing like, oh, I'm showing up brave and if I don't fight hard enough, then I'll be a loser or anything. No, I was drafted into this battle. I can't escape it. I mean, guys can leave Afghanistan and all those areas. It is inside my body. There's a terrorist with a hand grenade with the lever off, and he can drop it at any time, which he chose to do in March again. So I had to go back to battle, or now I'm choosing not to fight anymore because battle fatigue is real. There are soldiers that have to go back to the battlefield and they kill themselves. They no longer can handle it on an emotional level anymore. So no, I think we're warriors. I think it's a fight. I call myeloma insidious. It's just the most heinous of enemies that I've ever ran into, and I don't say that proudly or anything. I mean, plus whatever works for you. There's people that get offended about a lot of things in this world these days, and then they get into the post where they're very offended. If I see something that I don't like, I keep on scrolling. People don't.
I think that's. The corollary to the battle sort of statement or the warrior is that, ultimately there's heroism, and I think there's heroism even if you lose sometimes. And I have the deep conviction that when patients try harder because they look for more trials or perhaps more willing to sometimes go through another treatment, and where doctors try harder for their patients, I think there's something to be said about that in oncology.
People called me incredibly brave every time I took on another battle. And then surprisingly, people called me the bravest when I said I was done, I was going to stop. I never had so many shares, comments, likes, and love. So I'm a very calm, I always say I'm an optimist and a realist. And for me personally, nobody else, everybody gets to make his own choice. For me, it made more sense knowing how my family's put together that there would come a time where I would say enough is enough. Now, as I think we said before starting this interview, if there is a great trial that comes out of this interview, or that Brian gets on the phone with me and it's reasonable and it's doable and the side effects are not incredibly heinous, it's not like I want to bail out of life. I love life. I have a lot of stuff to do. So,
Of course. Is there anything that you wish I had asked you?
No, you're really good.
Oh.
But I would love to maybe revisit in some weeks or months, and if you have anything else to ask me, or I'm trying to think what I would want to ask you as a physician. I love that you're the type of physician that likes people to come in with knowledge, because I do think there are maybe of a different generation doctors that don't necessarily like that so much. And so it seems like you're a really good physician in like giving people the emotional openness, but definitely, I don't know if you do this with your initial patients. What I wish my doctor would have done initially is not only pointed to a poster that said there are all these services, but to literally suggest, going to see a psychiatrist, that this is a tough battle, and that, there's a lot of patients that can get depressed and stuff, and that there's help for us, not just as in a passing, but really having that conversation.
No, I think using the battle word again, sometimes there's so much going on at the beginning that some of those things get lost through the cracks, right? I'll give you an example. This is tangible. When we think about bone protecting agents, as Zomet and all those things, about half of myeloma patients get it when it should be close to 100%. I'm guilty of that as well too, and that's just because everyone is so focused on the core aspects of that battle. But I think the teams need to come together to do things just like what you just said. We need to have the support. We need to address the psychological needs, the social needs, nutritional, and so forth. So we'll work more at that. Certainly. Let me ask you one last question. Can I ask you can I send you a softball? Maybe say something about Dr. Orlowski. I know him well. I know you have great trust in him. Maybe you want to say something about that.
Oh, I'll just be so mean so I always tell, one time he didn't like it when I said it, but I said, if you have a 2 p.m. appointment with Bob Orlowski, that is code for 4 p.m. because you always wait so much. But when he was like, hey, that's not me, I go with Dr. Orlowski, that says how much time you spend to your patients. So what I love about him is that when you wait those 2 hours and you finally see him, he sat with me for 45 minutes to an hour, just listening to me. My husband's always like, we've got to bring him a bottle of wine next time because boy, because he will sit there and go, anything else? Anything else? And well, don't ask me anything else because I'll come up with something. Where I went to a local oncologist and she came in the room walking or talking and then left the room talking. I was like, whoa, whoa, whoa. I got a list of 6 questions I wanted to ask you. You could tell she was really trying to
just speed up.
Yeah, and that I didn't. That was the only time I saw her. I didn't like that.
You know, I can from my end, I can tell you, and I think you already know this. I'm going to say on behalf of everyone who works in the field, you have the commitment that we will be, you know, continuing on the search for better treatments. Hopefully, there is a future where, you know, we can think of myeloma like we think of a strep throat infection, you know, today. There's a future with abbreviated, cheap, side effect-free therapy. We're not there yet. There's a lot of progress. But you know, and it gives great meaning and satisfaction to everyone who participates in this, the patient organizations, the patients, but also doctors and nurses that, you know, and yes, there's wrinkles and there's concerns and, you know, there's some drugs that are better than others, but every time we get through a new approval, I think it's a better day for patients. So, you know, you have my commitment in that regard. And perhaps what we can do is just set a date. So maybe in a few weeks or, you know, a few months, whenever you're ready, we can revisit and then see where things are.
I would love that.
Okay. Anything else? You have the last word.
No, thank you so much for allowing me to say my stuff. Obviously, talking is important to me at this point in my life and getting my message out there. And that's what I want to do from the beginning, is just letting people know that they're not alone, to be an advocate, to, you know, when you have these symptoms. I think when doctors in the world become more knowledgeable about what myeloma is and patients know what myeloma is, which I had never heard from prior to, then when you have this backache or you have fatigue, you don't understand, you as a patient might go to a doctor and say, hey, could you check my light chains, or could you do a 24-hour urine? And a doctor who may be just a general physician, if he knew more about myeloma and he saw this patient who gets massages and keeps having this nagging back pain, not to just give them a x-ray, but maybe to do a PET scan so they could find tumors if they were there.
Well, thank you. I appreciate that. It's a pleasure being with you here in this conversation, and thank you again for your time.